Hello, everyone, and welcome to the Clinics Review Articles podcast series. I'm Carrie Holland, the managing editor for Infectious Disease Clinics of North America here at Elsevier. Infectious Disease Clinics is a quarterly publication consisting of review articles focused on a central topic related to infectious disease physicians. Today, we will be discussing the current September 2025 issue dedicated to musculoskeletal infections, guest edited by Dr. Laura Certain. She is a clinical associate professor in infectious diseases and an adjunct associate professor in orthopedics at the University of Utah Health and section chief in infectious diseases at George E. Whalen VA Medical Center, Salt Lake City, Utah. Also joining is contributor to this issue, Dr. Julianne Justo, clinical pharmacist lead in infectious disease and co-director of the antimicrobial stewardship program, Dartmouth-Hitchcock Medical Center, and clinical associate professor, Division of Medical Education, Dartmouth College Geisel School of Medicine, Lebanon, New Hampshire, and consulting editor, Dr. Helen Boucher, Dean and Professor of Medicine at Tufts University School of Medicine and Chief Academic Officer, Tufts Medicine, Boston, Massachusetts.
Hello, I am thrilled to be joined by Doctors Certain and Justo to talk about musculoskeletal infections. And, for all of us, this is among the most common reasons for infectious disease consultation in the United States, and such an important problem because of the morbidity associated with it. So we'll start off our conversation really by talking a little bit about the scope of the problem. And, one of the big themes that emerged from your edition was the importance of having the right team involved to optimize therapy. So maybe Dr. Certain, I'll start with you. Just from your perspective, tell us a little bit about the scope of this problem in the current era and what some of the key tenets are from your perspective in the multidisciplinary approach.
Great, thanks. Happy to be here to talk about musculoskeletal infections, which is a topic near and dear to my heart. And I'm glad that ID Clinics has put out this issue all about this topic. So musculoskeletal infectious disease encompasses a broad range of infections, but some of the most common ones would be prosthetic joint infections, infection after fracture fixation, vertebral osteomyelitis, infections after other spinal surgeries, diabetic foot infections, chronic osteomyelitis, etc. And by the nature of these infections, they almost always, maybe not always, but they often require both surgical management to remove as much of the infection from the body as possible. So you need a surgical team. Often you may need a wound care or plastic surgery team, sometimes podiatry or vascular surgery to ensure adequate blood flow to the space. And then the antibiotic management, as we'll talk about, is often prolonged and sometimes complex. And so it also requires assistance, often from an infectious disease trained pharmacist, to help manage these long-term antibiotics, which may be oral or may be IV, in which case then you're bringing in an infusion center, home health, maybe a PIC team. I neglected to mention our musculoskeletal radiology colleagues who often help with the diagnosis and evaluation of management of these things. So it's a big team involved in the care of most of these patients. And so that was why for this issue, we tried to make sure that for every article or chapter, it was not just infectious disease physicians writing it, but we included our surgical colleagues and our pharmacy colleagues.
Yeah, that's a really important point, right? Medicine's a team sport, and managing these complicated infections is really a team sport. And I think many of us are fortunate to work in centers where we have access to all these experts in the era of telehealth and things like that. I think that can help us extend our reach, but really great shout out. Is there anything, our listeners should know on the radiology front? I feel like, I started my career almost 35 years ago now with a lot of focus on diabetic feet. And, the study of probe to bone was done at my hospital many years ago. And today I see so many orders of CAT scans and MRIs and all kinds of things. And, tell me a little bit about what's the state of the art radiographically for diabetic feet?
So for diabetic foot infections, usually if we are concerned about osteomyelitis, which should be a concern if anybody sort of has a chronic non-healing wound or a wound that probes to bone, I will say a probe to bone does not prove they have a bone infection. It just should raise your suspicion pretty high. So we are using MRIs often as a way to evaluate the extent of osteomyelitis in a diabetic foot infection. Now, the downside to MRIs is that they can sometimes be a little bit oversensitive, and so they can sometimes overcall infection. But there actually was a study recently that showed that if you used an MRI to guide what kind of like where the surgical resection should be, that those patients actually did better. So that if you got an MRI ahead of surgery and tried to make sure that you use the MRI as guidance to resect all the infected bone, those patients had a lower risk of recurrent need for resection.
Let's talk about, in treating these infections, there are a number of ways antibiotics are delivered and a number of places antibiotics are delivered to. We see things like mixing antibiotics in bone cement, beads, irrigation. I've seen wound applications, a variety of types of applications of antibiotics. And you all raise quite eloquently the both efficacy and safety implications of these routes of delivery. And so I thought maybe we'd take a few minutes. And so maybe Dr. Certain, we'll have you start talking about, what are the surgeons doing in 2025 and what should we know as practitioners? And then maybe we'll turn to Dr. Justo to talk about some of the pharmacologic implications of these practices.
Yeah, that would be great, because there certainly are a lot. And I will say that while many of our surgical colleagues and wound care colleagues will use sort of topical or local applications of antibiotics, there actually is some evidence to support this use in the orthopedic literature. So it's not that they're just making it up as they go along. There is data to support the use of local antibiotics in orthopedics. But there are a variety of ways in which it can be given, and it's not always super well documented in the chart. It's not always easy to figure out what a patient got. So I will say it is worth talking to your surgical colleagues and with your electronic medical records team to figure out a way to make sure that it is actually documented who got what and how they got it, so that if on the off chance somebody has an adverse event or an allergic reaction or something, you're aware of everything that went into that patient. So I'll start with topical vancomycin powder. So this is just sprinkling vancomycin powder into a surgical site usually. This got its start in spine surgery as a way to reduce surgical site infections. It has more recently been studied in fracture fixation, so patients with open or closed. Now I don't remember off the top of my head what the Vanco study was, whether it was open, both open or closed, or just open. But the idea using vancomycin powder as a prophylactic, as a way to reduce the risk of surgical site infection. And the data, I mean, they're not a slam dunk, but there's data to support its use in that role and that it reduces the risk of surgical site infection. Topical antibiotics, where it's just the powder, it's not in any sort of carrier, it's not clear to me that they have a role in treatment of infection. They are mainly studied for prevention of infection. So that's one thing that people might see done is the sort of topical vancomycin powder. The other common route of antibiotic administration is mixing it into the bone cement, so polymethyl methacrylate bone cement. This is cement that does not dissolve. It can be used to fix hardware, or it can just be used to fill space. And it tends to elute antibiotics, or antibiotics elute from it over days to weeks, maybe months. It depends a little bit on the type of cement and how it was mixed and how many antibiotics are in there. But that is commonly used, say, if you have an infected fracture and they need to put a nail, an antibiotic-coated nail into the bone, they will coat it with this polymethyl methacrylate cement with antibiotics mixed into the cement. And then another common way that antibiotics are given are dissolvable calcium sulfate beads. So these are beads that the surgeons mix up in the operating room, mix in antibiotics, and then put the beads into the infected space, whether that's a gap in the bone or an infected joint space. And these beads, again, dissolve over days to weeks and release the antibiotics locally as they dissolve. So I would say the topical powder, usually vancomycin, polymethyl methacrylate cement, and these dissolvable calcium sulfate beads are the most common types of local antibiotics used. And more recently, though, some people are also giving intraosseous antibiotics. So in the surgery, they will give an intraosseous dose of vancomycin or cefazolin, say, for either treatment or infection prevention. And then finally, there's also some interest in the prosthetic joint infection world of sort of continuous irrigation of antibiotics in a joint. So they will continuously infuse antibiotics into the infected hip or knee over the span of several days. So those are the main ones. There may be others, but that is what I most commonly see. A question that also often comes up is sort of which antibiotics can be mixed into the cement in particular. And the reason it is limited is because the cement, when it sets, gets really hot. And so the antibiotic has to be heat stable, it is thought, to work well in that setting. But we can, so typically the antibiotics used are either vancomycin plus an aminoglycoside like tobramycin or gentamicin, or vancomycin plus ceftazidime in the cement, occasionally with an antifungal. Sort of on the pharmacy side, what you think about in terms of choice of antibiotics and concerns about either from the stewardship side, toxicity side, cost side, what happens on the pharmacy side when you're thinking of, when you get the request from the surgeon who's in the OR, is like, I want to put this in the cement or in the beads or whatever. What are some things that you consider on the pharmacy side?
I want to thank Laura for going through all of that. That was quite the list of all the various creative ways that we try to really do the best that we can to deliver the drug exactly where it needs to be for as long as it needs to be. There are absolutely considerations on the pharmacy side. I absolutely second what she said in terms of reaching out to IT and clinical informatics, your electronic medical record, and making sure that there is adequate documentation of at baseline what's being given and how. So, for example, it's not uncommon that I'm on ID consult rounds and the fellow is presenting the case and mentioning all the various antimicrobials that the patient is getting IV. And I also have to remind them exactly how many grams of vancomycin or grams of gentamicin had been given the day of the surgical debridement and implant placement, or replacement in that case. It is harder when you're talking about topical powders, I find, to document. We know how many vials that the OR pharmacy would have sent to the OR room, or how many vials were pulled from a medicine cabinet, so to speak. But then it's more difficult to document exactly how much made it to the patient. I'm very interested in seeing what's going to happen with intraosseous or the continuous intra-articular irrigations. I think those are a little bit easier when it comes to medication administration. But the whole theme of everything I'm saying, what do I worry about as a pharmacist? Can I at least document what was administered and how, so that if and when something may go wrong, I can go back and look. The best data that we have are for polymethyl methacrylate, the PMMA antibiotic loaded cements. And by far the most common options that I see utilized for musculoskeletal infections would be vancomycin is number one, followed closely by gentamicin, although I'm seeing a little bit more tobramycin being used these days, particularly, again, thinking about a stewardship perspective. If we're worried about non-lactose fermenting gram-negatives, in particular Pseudomonas, I personally would prefer tobramycin over gentamicin these days, if you know that that's a pathogen that's at play for the specific musculoskeletal infection. In terms of stewardship, the first thing that I think about is safety. I want to be able to document not only what was placed in there, but how much, because these patients usually have a long road ahead of them in terms of recovery. And a lot of what infectious disease will do is manage any potential side effects or adverse effects that they have from their medications. I personally think any local installation should be part of that consideration and in the differential for any potential adverse effects. I've absolutely, in my career, been the one to be like, hey guys, can we check a random tobramycin level in the bloodstream? Because we did put Tobra in that cement like 2 months ago, and I found and helped uncover systemic tobramycin concentrations that were contributing to the patient's acute kidney injury at the time. So safety is really top of mind, I think, for making sure we know at least what we're doing and how we're doing it, and document it appropriately. If I could talk real quick for like the biphasic kinetics, that matters to me from a safety perspective. The majority of ways that we're going to give the antibiotics locally, they will have biphasic kinetics with a big peak of release locally in the tissues within the first 24 to 48 hours, followed by a low and slow elution over the course of many weeks to potentially months, depending on the product and method that you use. I will say that may change moving forward in the next couple of months to years as more modern carrier methods are implemented that might optimize kinetics. But I always keep that in mind when I'm trying to judge if the local antimicrobial is related to safety. And then, of course, we have effectiveness. I think I'm very excited about, like we said, intraosseous, the intraarticular catheter delivery, although I'm a little bit worried about whether or not that's going to be logistically feasible long term. And then the resorbable carriers. I think all these efforts to modernize the carrier systems and delivery systems are really exciting.
And thanks very much, Dr. Justo. Anything you want to add, Dr. Certain?
Yeah, I think I want to agree with everything that Dr. Justo just said, and also that people are often concerned and have looked at sort of the risk of toxicity from antibiotic-loaded bone cement, and particularly concerned that the aminoglycosides can build up and cause toxicity. It is a rare side effect, but it does seem to happen. And it is mostly a concern in people with baseline poor kidney function, basically because their kidneys can't even keep up with the low-level elution that happens from the bone cement. And so then the aminoglycoside builds up over time. I will say at our institution, we actually do mostly vancomycin and ceftazidime now. There was a shortage of tobramycin maybe 5 years or so ago. And so we weren't able to get it. And so my colleagues in orthopedics asked me, well, what should we use instead? Like, what else can we use? And so we switched over to using ceftazidime because there was a little bit of data to support its use. And it hasn't seemed to cause a problem. Like, our efficacy seems to be fine. And it's a heck of a lot cheaper than tobramycin. So that is something we use. It also may be that part of the reason to have something with the vancomycin in the bone cement is that it helps the vancomycin elute. And most of these infections, or many of them, are gram-positive infections. So it may be that it doesn't actually matter as much what else you're putting in the bone cement, as long as there's something with the vancomycin to help the vancomycin elute better. But I'm definitely not an expert on bone cement kinetics. There are researchers and orthopedic surgeons for whom that is what they have been doing for decades, and so they would know more than I. And Dr. Justo has a comment.
I agree with everything you just said. So just to reiterate, the instances of aminoglycoside-loaded bone cement nephrotoxicity are relatively rare in the literature. Maybe it varies depending on the cohort, but you're talking maybe 5%, maybe less. These patients often are also getting systemic aminoglycoside therapy or other nephrotoxins, which can often cloud the picture. So I absolutely agree with the point that you make. And I love the concept of, let's figure out what our recipes are. Let's figure out what our surgeons, what our infectious disease colleagues, what everyone wants to, what pharmacy can reliably supply, and let's stick to that. So the concept of a tried and true gram-positive antibiotic, a tried and true gram-negative antibiotic. You and I will talk later about ceftazidime because I'm fascinated by that concept. I think that makes a lot of sense. And then stick with what you know, right? So anytime our pharmacy deviates from one of the standard ratios in terms of grams of vancomycin to 40 grams of a batch of PMMA cement for what we use, as an example, we're going to do a lot of extra digging. I just got an email in my inbox about that because we're using, in this case, a liquid amikacin for an NTM patient, which is something that we don't normally do. And that absolutely got escalated to me and my ID pharmacist colleague to make sure and dig deep into the elution kinetics before everyone moves forward with the case.
And this is another example of where you do want a multidisciplinary team, like especially in a non-tuberculous mycobacterial case that's an orthopedic infection and you're thinking of what antibiotics you can put in the cement. I mean, I want lots of help whenever I'm dealing with an NTM patient. Like, I definitely want a team around me no matter where that infection is. But I think especially when you're looking at, well, which of these NTM antibiotics can go in cement? Has anybody ever put them in cement before? What is the right surgery to do? It just highlights, again, the importance that you want your ID person on board, you want your ID pharmacist on board, you want the surgeon on board, you want the patient on board, you want all the people to have a coordinated attack on the bug.
Great points. And one thing I just want to highlight before we move on is one of the comments that Dr. Justo made, because I think that not all of us are in institutions where we have such great support, but your comment about the need to know and document what actually happened, like what actually happened in that operating room, how many grams of what were put where. And that's not always so easy to figure out. And I think that a great takeaway from your addition is the importance of having that data, because then on post-op day 3, when the creatinine is changing or some other thing is happening, you can be much more informed about what's going on. So thank you for that. So if that wasn't complicated enough, let's turn to sort of what many people feel are more bread and butter topics about systemic antibiotics for these infections, right? That's what we do almost all the time. And I hoped that you all would comment first a little bit on the question of parenteral versus oral therapy and how you approach that. So maybe I'll do the same thing, ask Dr. Certain to start, and then Dr. Justo to add the pharmacologic kind of perspective.
Happy to. I love to get on my soapbox about oral antibiotics for bone and joint infections, because for many decades, it was just accepted that if you had a bone and joint infection, you needed IV antibiotics. But that is based on expert opinion from the 1960s and not on any reliable data. And we have more and more data now indicating that oral antibiotics are just as effective as IV antibiotics in treating these infections, which really should not come as a surprise. Like, the benefit of IV antibiotics is that they get into a good level in your bloodstream quickly. So if someone comes in with sepsis, you want to give them IV antibiotics because you want the antibiotic to be at an effective level in the bloodstream as quickly as possible. But when we're looking at a long-term treatment course, it doesn't really matter how the antibiotic gets into the bloodstream as long as it gets there at an adequate level. And these days we have antibiotics that have good oral bioavailability. So the fluoroquinolones, doxycycline, amoxicillin, linezolid, clindamycin, trimethoprim sulfa, all of those have pretty good oral bioavailability. If you dose them appropriately, they can get to really high levels in the bloodstream. So there's no reason to think they wouldn't be as effective as IV antibiotics in treating these infections. There is some question about whether certain classes of antibiotics may be better than other classes in treating bone and joint infections. Like, there's hints in the literature that maybe quinolones are better for bone and joint infections, but that is a maybe, not an absolute. But that has nothing to do with the route of administration. That has to do with the class of antibiotics and how they work and maybe how they distribute in the body, though I think that is also a question. So in my mind, if someone has a bug that is sensitive to an antibiotic with good oral bioavailability and they have a functional gut and they can reliably take medications, then there is no reason to commit them to a long course of IV antibiotic. Dr. Justo, I don't know how you think about it, or if there's certain classes of antibiotics that you prefer in this situation or see as being more or less problematic.
Yeah, you and I drink the same Kool-Aid on this one. I am a very practical clinician. And if I have a philosophy, it's like the best med is the one that the patient can take. reliably, safely, and they can afford it, and like the whole thing, right? It has to like make it to the patient. So there's a couple like isms that I always like throw out there. Like the bug doesn't care how the drug gets there, whether it was oral, whether it was IV, it doesn't care. It's going to kill it just as well as long as you have enough there at all the sites of the infection that you're trying to treat. And then the other concept that I think is really important, everyone really, thankfully, everybody talks about picking oral agents with good bioavailability. And I love that concept. I want that to echo still, but that's just the beginning of making sure that we have adequate drug exposure. So for the most part, I would say everything that we know, and in that paper where we kind of summarize the case for how and when to use oral antibiotics for musculoskeletal infections, we talk a lot about IV seems to be equivalent to oral, but you got to think about which orals, right? So the devil's in the details there. And that's where, of course, my ID pharmacy hat goes like super nerdy. I agree with you. I think that some of the best, most consistent effectiveness data that I can find is the combination of levofloxacin plus rifampin as oral therapy, particularly for Staph aureus musculoskeletal infections. It is consistent across multiple studies, and they are impressive results to the point where, like, even if you had an IV therapy, like, I think I actually like that oral combination better if everything else fits, right? Assuming it's, you check drug interactions and the bug is susceptible and all that. So I think and part of the secret sauce, when you look at the oral agents that are reliable, yes, they have good bioavailability, but they all have very good probability of target attainment. And I mean, whatever dosage regimen, agent, dose, route, frequency, whatever you prescribe for the patient, chances are across a broad swath of the human population, you are going to have not good, but excellent exposures, not only in the bloodstream, but hopefully at the site of the infection, in the soft tissues, in the bone, hopefully at the site of the biofilm. We all argue about that, right? I don't know that really any antibiotic can truly sterilize a biofilm on its own. That's another topic for another day. We really need source control, right? So multidisciplinary approach here with our surgeon colleagues. But I think it's really important to get comfortable with the oral antibiotics for musculoskeletal infections that have the best data. So thank you for the invitation to write that paper where we have a table where it goes through, these are the regimens that we think have the best data. Levo-rifampin is that combination that's up in my list. Trimethoprim sulfamethoxazole is also up in my list. Linezolid, doxycycline. These are the agents that come to my mind as oral agents with not only excellent bioavailability, but they're going to fit the bill all the way down the line, excellent target attainment, and they're probably going to do very well for the patients if we think it through.
With those antibiotics, a lot of people get concerned about the long-term effects of being on, say, high-dose trimethoprim sulfa or long-term linezolid, long-term quinolones. There's concern about side effects. I mean, I would say that having a PICC line in and being on long-term vancomycin also has me concerned about side effects, and I see neutropenia from long-term IV cephalosporins also. So I don't think that necessarily means that they are more risky than IV therapy by any means. But what are some of the ones that more common side effects that you see in these patients who are on long-term antibiotics? And are there things that make you, like if somebody has quinolone-resistant MRSA, but it's sensitive to Clinda, Doxy, linezolid, and trimethoprim sulfa, are there things that would make you choose one over the other?
That's an excellent question. I will tell you, we're hitting the limits of where current published evidence is, in my opinion, in terms of weighing the benefits of particularly safety across these oral agents. It is an active area of study of not just for our center, but I know a lot of others as well. What I will tell you then, based on the evidence that I have seen, I am seeing more instances of adverse drug events with the moderate dosing of trimethoprim sulfamethoxazole. So I'm talking ballpark of like 8 to 12 milligram per kilo per day of the trimethoprim component. That's about 2 double strength twice a day for most average size adults with normal renal function. If you have patients on that particular regimen, that's a lot of trim sulfa. If I personally am not comfortable giving that on a routine basis to patients that are elderly, 75 years of age or older, I try to find something else. Similarly, if the patients have chronic kidney disease, or you just know that they have other risk factors for propensity of nephrotoxicity, that's a little bit risky of a regimen, in my opinion. So I would move to something like doxycycline if it's available. We also sometimes use minocycline here locally as well, but you have to worry about skin discoloration, particularly with long-term use with minocycline. Doxycycline has like sun sensitivity and stuff like that. But overall, as long as you counsel patients and they know about these things ahead of time, tetracyclines are generally well tolerated. And again, beautiful probability of target attainment. So I like those. But I might worry about them in terms of like obese patients, because let's be honest, we're still giving like tiny doses of oral tetracyclines, in my personal opinion, because we didn't have PK/PD science that really optimized those dosing for those old tetracyclines when they came to the market. So then if I worry about morbid obesity, I might shift to something like linezolid. I personally really like linezolid. I have a respect for its side effects. We have actually a lot of good data about its toxicodynamics in terms of like how much you give, when it starts to get south, when the thrombocytopenia will set in at about 10 to 14 days, when the neuropathies will start to set in once you get past a certain duration. And we locally have had a lot of success with linezolid therapeutic drug monitoring. So we implemented that here locally at Dartmouth within the last 2 years. And that was mostly based off of the data, a lot from the Italians and the Spanish that have been doing this for over a decade and actually have a lot of published data for linezolid TDM as a strategy to modify, in particular, the bone marrow suppression and cytopenias. Emerging data, whether or not it'll work so great to avoid neuropathies. But those are some of my initial thoughts as to how and when I might prefer certain agents over others.
Very, very helpful and really important for clinicians on the front line. Before we leave this topic and go to one last thing, I'll ask you, Dr. Justo, what is your sort of routine guidance for monitoring in the OPAT setting, whether a patient is on intravenous or oral therapy for long periods?
I love that you brought this up. Our OPAT and COPAT group is actually actively revising our guidelines for laboratory and adverse event monitoring, in part because we are making a shift to an intentional shift to incorporate more patient-centered care plans that might have more orals. And within our division, a lot of people, I think, were accurately concerned about if you have somebody on orals, is there a sense that they might not be followed as closely? So we are in the midst of hashing out all those details. I will again point folks to the review article within this edition, because it does have for each oral antimicrobial that we're discussing that has data for musculoskeletal infections. We do make some suggestions for routine lab monitoring. I'll be honest, if I'm giving someone, as an example, 2 double strength twice a day of trimethoprim sulfamethoxazole to treat bone and joint infection, I'm probably going to want, BMP, a basic metabolic panel to check in particular BUN and creatinine once a week. And I'm also going to want a CBC once a week. I would get baseline LFTs, and I probably wouldn't check liver function tests after that unless the patient has underlying risk factors, which at that point we could argue whether or not we're even picking that particular agent over others. So that's an example of probably one of the more heavy and frequent monitoring that I would do with the agent that I told you I'm more concerned about. In contrast, something like oral clindamycin, if that was an agent that we selected, I don't know that we necessarily have almost any routine monitoring that we would do. I might check a set of basic labs at 4 weeks, but if everything is okay, you probably can push that out to even 3 months or 6 months. So I think we're still working on that internally, but maybe that'll give you a sense of the spectrum across the agents. I don't know, Laura, if you do anything different.
I mean, I think for our patients on what I consider the sort of high-risk orals, which again are the basically linezolid and high-dose trimethoprim sulfa, we're checking labs every 1 to 2 weeks. But for most other oral antibiotics, so high-dose amoxicillin, doxycycline, clindamycin, we check them maybe once a month when they're in their initial phase, just to make sure things are going okay. I sort of check them when they come to see me in clinic, but I'm not typically asking them to go in separately to get other labs checked unless they're feeling poorly.
And there is emerging data to comment specifically on IV OPAT, which is not necessarily the focus of the original discussion, but there are some data to suggest that we have some work to do for diagnostic stewardship for IV OPAT. It's very common that you'll see every 4 weeks, someone will get a complete metabolic panel and a complete blood count, and that might be overdoing it for the rates of toxicities that we might see as a, across the board, we're going to do this in every single person for the whole time.
Yeah, I think it is really hard to know because you also have to know like what rate of adverse event is worth 100 unnecessary tests. Like, is that too much? Like, what is the number needed to treat or number needed to intervene
in this space? Yeah. I agree.
Yeah, well, great points. Thank you. And very practical, which is super helpful. I think one of the takeaways is that I still think there are people out there who don't appreciate the fact that oral OPAT can indeed be as toxic as IV. And I think that's just an important thing to think about as we think about in a, maybe not as data-rich environment as we would like, but as we think about how we manage these patients. So thank you. For the last topic, I thought I would ask you all to opine on. This one is a doozy, and I'll let Dr. Certain take the first stab, but I know Dr. Justa will have something to say about this. And that is just asking you to comment on the updated guidance and your perspectives on dental prophylaxis for hip and knee replacement, which is among the most common questions that many of us get at cocktail parties and other places. So Dr. Certain, over to you.
Yes, I am happy to talk about this. The short answer is please don't bother. And then we don't have to talk about it anymore.
I think just end the podcast right there.
Yeah, done. Don't do it. But look, we can say more about that. So basically, it is very plausible that you could imagine an invasive dental procedure that causes a transient bacteremia could lead to an infected prosthetic joint, because we know that some prosthetic joint infections occur from a transient bacteremia, or at least they seem to. So some are from like a surgical site infection. The bacteria get in there shortly after surgery and then they cause an infection. But there are clearly some where it's a hematogenous process where the patient was bacteremic and then the bacteria in their bloodstream found their way into the prosthetic joint, and then that caused the prosthetic joint infection. And so that led to the concern that dental procedures that can cause a transient bacteremia with mouth flora could lead to a prosthetic joint infection. So there was sort of a plausible story. Therefore, most surgeons and dentists just started giving patients oral amoxicillin. Usually it's 2 grams of amoxicillin about half an hour before any invasive dental procedure. Invasive basically meaning anything that manipulates the gingival mucosa, so most dental procedures, with the idea being that this could reduce the risk of prosthetic joint infection, similar to how patients with prosthetic heart valves were advised to take amoxicillin. As most of our listeners probably know, we are giving oral antibiotics to fewer patients for endocarditis prevention perspectives now. We are also toning back on who, if anyone, needs antibiotic prophylaxis for dental work just because they have orthopedic hardware somewhere in their body. And the reason we're pulling back is because multiple studies have tried to find a link between dental procedures and prosthetic joint infections, and none of them have been able to find such a link. And so given that there's no evidence that dental work is associated with prosthetic joint infections, and likewise, it doesn't seem like the antibiotics that they are getting reduces the risk, the American Academy of Orthopedic Surgeons has recently revised its recommendations on dental antibiotic prophylaxis, such that for most people, for the average person with a prosthetic joint or orthopedic hardware of whatever kind, antibiotic prophylaxis is not recommended. There is still some debate for highly immunocompromised patients or patients with a history of recurrent prosthetic joint infections who might be, for whatever reason, at increased risk. That's a little bit more of a gray area, not because there's evidence that dental work is a risk in that population, but just because they were not super well represented in the studies that exist. And the thought is that we have a lot less room for error. Though you also don't want those patients to get C. diff because that's a disaster for them as well. But the main takeaway should be that it is no longer the recommendation that everybody with a prosthetic joint gets amoxicillin before their dental procedures.
Thank you. Anything to add, Dr. Justo?
I mean, she said what needed to be said. I 100% co-sign that recommendation to avoid that prophylaxis. I think it's just to recognize that this is a multidisciplinary stance at this point. So not only the American Academy of Orthopedic Surgeons, but also the American Dental Association has gotten behind this recommendation to change this practice. Anytime we talk about giving a patient a medication, for me, it's always the same calculus. Do the benefits outweigh the risks? And there are risks to every single dose of an antibiotic that somebody can take. You are dramatically altering their flora, even with a single dose of amoxicillin. That is a massive hit to their flora. And when you think about the fact that some of these patients with prostheses can have multiple dental procedures, and you go back and we see this for some of our patients, they can have, it's quite a bit actually, of outpatient preventative antibiotics that are being given for this indication that's honestly based on pretty shaky data. So it doesn't seem to pass the sniff test any longer. And it seems like the risks at this point outweigh the benefit to routine administration of antibiotic prophylaxis.
Yeah, I was just going to say, I remember, because often most surgeons and probably many ID doctors will have an anecdote, like we'll have the patient who was doing fine and then had whatever dental work, and then 2 weeks later came in with a streptococcal prosthetic joint infection. And it's like, clearly it was the dental work. And that anecdote is very persuasive. But I will say, I also saw a patient who had a joint replacement and then several years later went to have routine dental work. They had a reported penicillin allergy that was not verified, so they got clindamycin for their dental work, and then were referred to me because they ended up with recurrent C. diff colitis from the clindamycin. And so I think, which again, that's just an anecdote, like that was just one case, but to me, that is also an argument against the routine use of antibiotics, and just a good reminder that antibiotics are not benign, and so you need to choose whether or not it is worth giving them in every single case.
Excellent advice. Thank you both, Dr. Certain and Dr. Justo, for this great discussion and for leading what is a really valuable addition to the armamentarium in terms of helping clinicians who care for these very, very frequent infections. It was great to be with you and look forward to working together again soon. Thanks a lot.
Thanks so much for taking the time to discuss these important topics, Dr. Certain, Dr. Justo, and Dr. Boucher. And thank you to our listeners for joining us for this edition of the Clinics Review Articles podcast series. For an exclusive discount on the issue we discussed today, focusing on musculoskeletal infections, visit us.elsevierhealth.com/expert. Infectious Disease Clinics is available for individual print subscription with accompanying online access, as well as individual online-only access, and is also available on the Elsevier electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 65 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on X at Clinics Reviews and at ID Clinics, and subscribe to the Clinics Review Article podcast wherever you get your podcasts.